Thank you very much. Now, can I request Sanjay Sharesta to come up? His topic is pulmonary embolism.
Good morning. Thanks to the National Heart Foundation and especially to Fazila Malik Madam for this invitation. This is a great honor for me to speak here. I have a special attachment, respect and love for this country because I started my medical studies from this country, Mymensingh Medical College, and I'd like to take every opportunity to come here again and again, and whatever I am is because of this country. So I love this country a lot. Thank you so much. So my topic is pulmonary embolism, especially intermediate risk group in having normotensive shock. Rudolf Ludwig Karl Virchow is considered to be the father of thrombosis as well as the victim. He was a German doctor who described the famous Virchow's triad that leads to thrombosis, endothelial injury, abnormal blood flow, and hypercoagulability. However, ironically, in 1902, at the age of 80, he fractured his femur after falling from a streetcar, and it's speculated that he died of thromboembolism. Why is it necessary to talk about pulmonary embolism? Because it has a very high rate of misdiagnosis, very high mortality. Methods of risk stratification are still evolving, and optimal management are still not finalized. We know that cardiovascular disease is the #1 killer according to the global burden of disease, and pulmonary embolism is the third one among cardiovascular disease after MI and stroke. Pulmonary embolism is a hidden killer. It is the hidden burden in cardiology. Autopsy studies repeatedly show the massive underdiagnosis. The most common unexpected findings at autopsy in elderly hospitalized patients. In many autopsy studies, up to 60 to 70% of fatal PE cases were not suspected clinically. And studies show that 25 to 40% of confirmed PE patients were initially treated as acute coronary syndrome or heart failure. And PE is usually undercoded on death certificates, and global burden of disease relies on death certificate to categorize diseases. And that's because elderly patients, elderly people with pulmonary embolism may present with chest pain, and it's documented as myocardial infarction, dyspnea documented as heart failure and pneumonia, and collapse documented as cardiac arrest. So it is usually undercoded in death certificate. Otherwise, maybe the global burden of disease would make this even higher. So physicians rarely perform confirmatory imaging in the last hours of life, and when comorbidities exist, PE is often not even considered. And after 70, you can see that pulmonary embolism incidence rises very sharply. And what about Nepal? There's a super specialty center, Manmohan Cardiothoracic Vascular and Transplant Center, where they analyzed 45 patients with pulmonary embolism, 9 were in cardiogenic shock. They thrombolized 6 with STK. However, there were 7 in hospital death, leading to a very high rate of death, that is almost 80%. So there is a need to identify pulmonary embolism patients that may progress from intermediate risk to high risk before it is too late. And the 2019 guideline recommend strict risk stratification on the basis of RV dysfunction and hemodynamic status. Assessment of RV dysfunction is the critical factor in guiding management because it indicates severities, stratifies risk categories, has prognostic value, and helps in treatment decision. And we already have very well established markers of RV dysfunction among cardiac troponin and BNP are the biomarkers, and CTPA and echo are the imaging techniques. It is risk stratified as low, high, or intermediate risk. I'm talking about the intermediate risk, which is the largest group, 50 to 60%, having a mortality in 30 days ranging from 5 to 15%, and it is further categorized into intermediate low risk that has either RB dysfunction or raised biomarkers, and intermediate high risk that has both RB dysfunction and raised biomarkers. And this is the largest group, and initially, according to the guidelines, it is treated only with anticoagulation and monitored in the hospital. However, some deteriorate suddenly and may require reperfusion therapies. And failing to recognize a special group within this group is the normotensive shock pulmonary embolism patients that has a very unfavorable prognosis. And the current guidelines emphasize the need for additional markers to identify those at this higher risk. The new markers could be as TAPSE, PASP ratio to determine the RB dysfunction, as well as newer echo parameters like RB strain using spectral tracking echocardiography to measure global longitudinal strain, and it is very useful in identifying subclinical RB dysfunction. And a study on 30-day mortality showed that RBGLS of less than 70% had a 25-fold higher mortality risk compared to those with RBGLS more than 17, and RBGLS values were significantly lower in non-survivors, that was 15 compared to survivors. And RBGLS was the only echo parameter found to be statistically significant in patients predicting mortality in multivariate analysis. So what is this normotensive shock group? So the patients have normal blood pressure, that is systolic blood pressure is above 80. However, the cardiac index is less than 2.2 liter per minute square. So that is, they have significant hemodynamic compromise due to severe RB strain, and the flash registry showed that 34% of patients in the intermediate high risk group were in actually normotensive shock. So high risk of further hemodynamic collapse. It's very important to identify this subgroup. And for the identification of this subgroup, normotensive shock, plasma lactate has been indicated. Plasma lactate levels of more than 2 milligram per liter has been found to be a significant biomarker of normotensive shock and adverse outcomes in PE, as well as there is a need to calculate cardiac index bedside. With bedside echo, it's not very difficult. Using velocity time integral, we can calculate the cardiac output and then the cardiac index. And though according to the recent guidelines, only anticoagulation is recommended for the intermediate group, there are studies that are showing reperfusion therapy for intermediate high-risk pulmonary embolism, both with full dose and half dose. There's a study known as PITO trial that has full dose of 100 milligram over 2 hours, and that has significantly reduced death and hemodynamic collapse within 7 days, but there was an unacceptably higher major bleeding risk of 10 to 20%, as well as high intracranial hemorrhage. However, there is another one, MOPED trial, that uses only half dose, 50 milligram over 2 hours, and that has shown also
Can you
a very
have
good...
2 minutes more?
Okay. And that has also shown a very good outcome in reducing pulmonary hypertension, recurrent PE, and with significantly low rates of pulmonary embolism. Newer treatments with catheter-directed treatments are also coming up, and interventional treatment with catheter-directed thrombolysis and thrombectomy are also being recommended by the updated current guidelines, especially in patients with normotensive shock. And in recent years, a growing body of evidence supports catheter-directed treatment as a viable first-line therapeutic approach for patients with intermediate high-risk PE. So finally, the takeaways: pulmonary embolism remains a major clinical challenge with unacceptably high misdiagnosis, is a huge hidden burden in cardiology, and mortality. And risk stratification based on RB dysfunction and identifying stable patients at risk of decompensation remains challenging. And 1/3 of the intermediate high-risk patients could be in normotensive shock, and we should be using lactate as the biomarker and also bedside echo to calculate the cardiac index. And growing studies also support catheter-directed treatment as promising escalation options in intermediate and high-risk PE. Thank you.
Is there any question to him? Yes, please. Please
First,
identify yourself
yes,
and then ask the
introduce.
question.
Hello, hi. I'm Dr. Tasnua Sarakashim. I'm Associate Professor in Kidney Foundation Hospital. I'm a nephrologist. So thank you for the brilliant presentation. I have a question. I've noticed that full treatment with thrombolytic drug in PE has a risk of 10 to 20% of bleeding. What about in dialysis patients? They're at increased risk of hemorrhage. We get a lot of patients with intracranial hemorrhage. Is there any data or any guideline for these patients? Like what kind of, because we do get PE, we get risk of bleeding as well. So is there any guideline for that? Or any data that supports the dose of thrombolysis in these patients?
Recommended guideline is to use thrombolysis at present, thrombolysis for the high risk and anticoagulation for the intermediate risk. And the main thing is, again, like there's a very high need to identify the normotensive shock patients. But exactly for the hemodialysis patients, I'm not very aware of that.
Thank you.
So, thank you. Any other question? We take another question. Yes, please.
Good morning. I am Dr. Shamim Chaudhary from National Heart Foundation Hospital. My question is that we have experienced 2 or 3 patients. One patient with thrombolyzed, patient went back, and on the follow-up, there is still the thrombus on the pulmonary arteries. What will be the management in this type of patients?
So you thrombolyzed a high-risk patient
High-risk patient was in
who has
shock.
a massive pulmonary embolism with shock.
Yeah.
Hemodynamically. And anyway, you saved the patient, right?
Yeah, we have saved the patient, and on follow-up, patient again come and we did the echo and also the CT pulmonary angiogram. It shows the thrombus still in the arteries.
So probably catheter-directed treatment would be good for this patient if possible. I don't know whether we are doing catheter-directed treatment in Bangladesh or not. But I think it would be...
Patient, you can, high burden patient in acute situation, you can go for a thrombectomy. If the thrombolytics agent fails to resolve the thrombus and the mass is huge, we should go for the thrombectomy, catheter-based therapeutic option. But if it is in chronic case, when you are doing echo in the outdoor, we have to maintain the anticoagulant therapy.
Now, patient
that we can maintain for long period.
Patient was on anticoagulation after the thrombolysis, and the follow-up after 3 months, patient we did the echo and CTPA, and still the thrombus was there, and RB function was deteriorating. Patient's RB function was deteriorating at that moment. Chronic case.
We can take a comment from another discussion. Please, Khalid.
Thank you. I think what you're referring would be something, when you follow up, you always worry about the condition called CTAP, chronic thromboembolism pulmonary hypertension. So obviously we have to establish with an echo, and then we actually can do a pulmonary angiogram to establish is that a CTAP. And CTAP therapy was historically done with a open heart surgery, but now intervention cardiologists, which can do pulmonary embolism and can do thrombectomy, is the way to go. Thank you.
Okay, thank you very much.
Thank you.
Okay, now please call the next speaker.